Hi friends, welcome to my YouTube channel Dr.Sreenivas Medical Concepts. I am Dr. Sreenivas, neurophysician from Andhra Pradesh and a medical author of the book Focused Neurology. Today we are going to talk about an interesting topic, anti-epileptic therapy, and I believe it will be useful to pediatricians, physicians, neurologists, neurosurgeons, anesthetists and psychiatric resident PGs. Epilepsy is a very broad specialty, and anti-epileptic therapy is also very broad specialty. So I'm going to touch upon only the concepts and most important points of anti-epileptic therapy. So here we go. Before we start anti-epileptic therapy, we should know what is seizure and what is epilepsy. Seizure is a transient occurrence of signs and symptoms due to abnormal, excessive and synchronous neuronal activity in the brain. So seizure is a transient occurrence of signs and symptoms due to abnormal, excessive and synchronous neuronal activity in the brain. So what is epilepsy? Epilepsy is seen in a person who has a risk of recurrent seizures due to underlying chronic pathology. So epilepsy is usually due to more than 2 unprovoked seizures. So now we'll see how anti-epileptic drugs can be given to combat epilepsy. Anti-epileptic drugs. Almost all anti-epileptic drugs can be put in these 5 categories. The first is the sodium channel blockers. They block the entry of sodium and therefore they limit the spread of seizure activity. So what are these sodium channel blockers? They are phenytoin, carbamazepine and sodium valproate. So first is sodium channel blockers. The second category are calcium channel blockers. Calcium channel blockers prevent the entry of calcium and thus will not allow the spread of seizures. They are especially useful for absence seizures. So the drugs in this category are ethosuximide and sodium valproate. The third category of anti-epileptic drugs are Gaba Agonist. We know that the seizure occurs whenever the GABA gets decreased or glutamate gets increased, persons will have seizure activity, because GABA is a neuroinhibitory substance and glutamate is a neuroexcitatory substance. So whenever gamma aminobutyric acid decreases or glutamate starts increasing, persons throw seizures. So we have to give GABAergic drugs so that the GABA activity is increased, the neuroinhibition is increased and seizures get suppressed. Otherwise, we can also give glutamate antagonists so that the excitation gets suppressed and the seizures are under control. So the third category are Gaba agonists. What are these Gaba agonists? The benzodiazepines, phenobarbital and probably sodium valproate. The fourth category is, as I said, inhibition or antagonist of neuroexcitatory substance, that is glutamate. They are felbamate, lamotrigine, again probably sodium valproate. So if you see the first 4 categories, the sodium channel blockers, the calcium channel blockers, the GABA agonist and glutamate antagonist, almost sodium valproate comes into all these 4 categories, and therefore sodium valproate is a broad spectrum anti-epileptic drug. I repeat, sodium valproate is a broad spectrum anti-epileptic drug because it can act as sodium channel blockers, it can act as calcium channel blockers, probably GABA agonist, probably glutamate antagonist. So sodium valproate is a broad spectrum anti-epileptic drug, very useful for almost all types of seizures. But the only problem with sodium valproate is that it is a teratogenic drug, very dangerous to give in a pregnant lady who has epilepsy. Yeah. So these are the 4 categories of anti-epileptic drugs. What is the 5th category? 5th category is a very interesting category. It has got nothing to do with all these blockers or the chemical substances. It acts on the synaptic vesicle protein binding SV2A. So it inhibits SV2A and thereby it inhibits the action potential. The drug which comes in this category, that is the synaptic vesicle protein SV2A inhibitor, is levetiracetam. So levetiracetam is a wonderful drug. Levetiracetam is becoming very popular. Why levetiracetam is becoming very popular? Because levetiracetam has not got drug interactions. Levetiracetam does not have drug interactions. To understand this, I need to introduce a concept which is known as enzyme induction and hepatic enzyme inhibition. Hepatic enzyme P450 induction, hepatic enzyme P450 inhibition. So there are certain drugs which are hepatic enzyme inducers like phenytoin, phenobarbital, carbamazepine. Phenytoin, phenobarbital, carbamazepine are hepatic enzyme inducers. So the drugs which get metabolized by hepatic enzymes get metabolized fast and therefore their duration of action decreases. So these are hepatic enzyme inducers. Then we have hepatic enzyme inhibitors. The hepatic enzyme inhibitors are sodium valproate. This inhibits hepatic enzymes and therefore drugs which get metabolized by hepatic enzymes, their action gets prolonged and therefore when you give sodium valproate, the drugs which get acted by hepatic enzymes, you have to reduce the dose, otherwise their action gets prolonged. The classic example is lamotrigine. So when you give sodium valproate, it inhibits hepatic enzymes and therefore lamotrigine, which gets metabolized by hepatic enzyme, since the hepatic enzyme is inhibited, the action of lamotrigine gets prolonged and therefore you have to be specially careful when you give sodium valproate with lamotrigine, because you have to decrease the dose of lamotrigine because its duration of action gets increased, because sodium valproate inhibits hepatic enzymes and therefore the metabolism of lamotrigine is inhibited, therefore the duration of action of lamotrigine is prolonged and therefore when you give sodium valproate along with lamotrigine, you have to decrease the dose of lamotrigine. But another important thing is that the sodium valproate and lamotrigine is an excellent combination, so that some neurologists use this combination for refractory epilepsy also. So having understood the concept of hepatic enzyme induction, hepatic enzyme inhibition, now we can focus on levetiracetam. So what is the advantage of levetiracetam? It neither inhibits hepatic enzymes nor induces hepatic enzymes nor gets metabolized by the liver. Since it doesn't get metabolized by the liver, since it does not induce hepatic enzymes, since it does not inhibit hepatic enzymes, there is no drug interaction. It is absolutely safe. Levetiracetam, absolutely safe. There is no drug-drug interaction. Because there is no drug-drug interaction, because it is very much safe in pregnancy and it can be used for most of the seizures, levetiracetam is slowly emerging as the most popular drug as a broad spectrum anti-epileptic drug. Especially in elderly also can be useful because there are no drug-drug interactions. So levetiracetam is becoming slowly the drug of choice. Right. Now having understood the anti-epileptic drugs which are placed in all these 5 broad categories, now let's see the most important points of each drug and which is really important and exciting for the clinical practice. Let's start with phenytoin. As I said, phenytoin and carbamazepine are enzyme inducers. What is the point which we need to know about phenytoin? One of the important points we need to know about phenytoin is that unlike other drugs, it follows non-linear kinetics. Very, very important. Phenytoin follows non-linear kinetics. What does that mean? As you increase the dose, the action also increases, but up to a certain limit, beyond which the action gets disproportionately increased as to the dosage increased. So, for example, if you increase from 100 to 100, the action increases. 200 to 300, it again increases. But when you go from 300 to 400 or 400 to 500, it becomes disproportionately increased and can cause lot of untoward or side effects. So we need to be very careful with phenytoin. The usual dose is 5 milligrams per kg body weight. The usual starting dose is 200 milligrams, and therefore be careful. It follows non-linear kinetics. So you can go up to 400, 500 milligrams, but beyond which it produces undesirable side effects like ataxia, like gum hypertrophy, or nystagmus, or hirsutism. So we have to be very careful with phenytoin. It follows non-linear kinetics. Yeah. Now coming to the second drug, carbamazepine. As I said, this is also hepatic inducing drug. Few important points of carbamazepine is that it causes auto-induction. What is auto-induction? This drug metabolizes itself. So when you give carbamazepine, there is auto-induction. This drug metabolizes itself. The carbamazepine metabolizes carbamazepine itself, and therefore the half-life gets shortened and shortened. So it gets steady after about 4 to 5 weeks. So you have to be very careful with carbamazepine. It follows a tendency which is known as auto-induction, wherein its half-life gets decreased. Second thing, carbamazepine is the drug of choice for focal seizures. So any person who comes with focal seizures, carbamazepine is the drug of choice. What is this focal seizure and what is this generalized seizure? Focal seizure is restricted to only one part or a particular part of the body. Generalized seizures, it spreads to both the cortices. Person loses consciousness and it's a generalized seizures. Focal seizures are usually because of a pathology. So focal seizures, you need to always investigate. There will be some pathology. It could be a tumor, it could be neurocysticercosis, it could be tuberculoma. Some part of the brain gets irritated and starts throwing focal seizures. Whereas generalized seizures, it could be generalized, it could be genetic, it could be idiopathic, it could be anything else. But focal seizures, usually there's a cause. So focal seizures always have to be investigated, and the drug of choice for focal seizures is carbamazepine. And then another important point about carbamazepine is that it causes toxicity because of the metabolite epoxide. So about carbamazepine, the three important points we need to know is that it induces its own metabolism, what you call it as auto-induction. It is a drug of choice for focal seizures, and then it can cause toxicity because of epoxide. So to overcome all these disadvantages, there's another drug which is introduced in the market, which is known as oxcarbamazepine. So what are the advantages of oxcarbamazepine or carbamazepine? One, oxcarbamazepine has got no auto-induction like carbamazepine. Therefore, it does not induce its own metabolism. One. Second thing, oxcarbamazepine is the drug of choice for all neuralgias like post-herpetic neuralgia, trigeminal neuralgia. We may be wondering why or how anti-epileptic drugs are useful in painful neuritic conditions. These are anti-epileptic drugs. How are they useful in painful conditions? Yes, they are useful. As I said, carbamazepine and phenytoin, they belong to the group known as sodium channel blockers. So when they belong to the group sodium channel blockers, they block the entry of sodium, and hence they prevent the transmission of impulses. So they prevent the transmission of epileptogenicity. They prevent the transmission of painful impulses also. So sodium channel blockers like phenytoin or carbamazepine are not only used in epilepsy, they can use in the painful conditions also, because they are sodium channel blockers, and therefore they block the entry of sodium, so they prevent the spread of the transmission of the nerve impulse. So phenytoin, carbamazepine, oxcarbamazepine can be useful for trigeminal neuralgia or post-herpetic neuralgia. Third point is that carbamazepine, as I said, can cause toxicity because of epoxide, whereas oxcarbamazepine does not produce epoxide, and therefore there is no toxicity. Another doubt may arise how to convert carbamazepine into oxcarbamazepine, and you want to change over because of the disadvantages. The ratio is in the ratio of 3:2. Carbamazepine to oxcarbamazepine, the ratio is 3:2. So according to this ratio, you can convert the carbamazepine to oxcarbamazepine. Right. Next is the sodium valproate. Sodium valproate, unlike the other drugs like phenytoin or carbamazepine, which are hepatic enzyme inducers, this is hepatic enzyme inhibitor. So very important point. Carbamazepine and phenytoin are hepatic enzyme inducers, whereas sodium valproate is enzyme inhibitor. Since it inhibits enzyme, the lamotrigine which gets metabolized by hepatic enzymes, since the enzyme is inhibited, the action of lamotrigine gets prolonged because it does not get metabolized. And therefore, when you give sodium valproate and lamotrigine, you have to be careful. You have to start decreasing the dose of lamotrigine because sodium valproate is hepatic enzyme inhibitor. The problem with the sodium valproate is that it is one of the most dangerous drugs to be used in pregnancy. It causes teratogenicity. It causes neural tube defects, especially when the dosage is increased beyond 700 milligrams. So sodium valproate, though it's a wonderful drug, it's a broad spectrum anti-epileptic because it can cause sodium channel blockade, calcium channel blockade, it increases GABA, it antagonizes glutamate. Despite having all these actions and being a broad spectrum anti-epileptic, the major disadvantage of sodium valproate is that it cannot be given in pregnant women who are having epilepsy, especially when the dose is more than 700 milligrams because it causes neural tube defects. However, if you need to continue sodium valproate where it becomes a necessity, you add folic acid or try not to increase sodium valproate beyond 700 milligrams. Yeah. The next drug which we are going to talk about is lamotrigine. Lamotrigine, it has got a synergistic effect with sodium valproate. In fact, the combination, the synergistic effect of lamotrigine is between lamotrigine and sodium valproate is so good that a lot of neurologists have started using this combination even in resistant epilepsy because it has turned out to be a wonderful combination, lamotrigine and sodium valproate. But you need to be careful, you need to reduce the dose of lamotrigine when you give sodium valproate. The second important point is that lamotrigine, according to the studies, it is safe in pregnancy. So pregnant ladies who are having epilepsy, the two anti-epileptic drugs which are really safe in epilepsy are, one is lamotrigine, second is levetiracetam. The drug which is most contraindicated and highly teratogenic is sodium valproate. So in pregnant women with epilepsy, avoid sodium valproate as far as possible and recommend levetiracetam or lamotrigine. The third important point about lamotrigine is that it can cause rash. So when you give lamotrigine, you need to be careful that it can cause rash, right? Now, coming to one of the most popular drug of recent times, anti-epileptic drugs, is levetiracetam. As I said, it has got a unique action unlike the other anti-epileptic drugs. So it acts by binding the synaptic vesicle protein 2A and inhibits the spread of action potential. So levetiracetam acts and prevents the action of action potential. As I said, levetiracetam neither gets metabolized by liver, neither induces hepatic enzymes, nor it inhibits hepatic enzymes, and therefore levetiracetam is very, very safe. It has got no drug-drug interaction. It can be given even in elderly people who have got comorbid conditions because there are no drug interactions, and then levetiracetam is very safe in pregnancy. So even in pregnant women with epilepsy, you can give levetiracetam. And therefore, levetiracetam is slowly gaining popularity and is becoming a highly popular anti-epileptic drug. Yeah. Now coming to benzodiazepines, we need to know a few important concepts in benzodiazepines. Have you ever noticed that we give lorazepam, midazolam, and diazepam for acute seizures or for status epilepticus, but on a long-term basis, we don't give these benzodiazepines, that is midazolam or diazepam or lorazepam. We give drugs like clonazepam and clobazam on a long-term basis, but we don't give these three drugs on a long-term basis. So we give diazepam, lorazepam, midazolam. In fact, these drugs are really good for acute seizures and they are the drugs of choice for status epilepticus, especially lorazepam. But why we don't give on a long-term basis? Because these three drugs are 1,4 benzodiazepines. Midazolam, lorazepam and diazepam are 1,4 benzodiazepines, and therefore there is tolerance. Because of the tolerance, you cannot give it on a long-term basis. They are all 1,4 benzodiazepines. whereas clobazam and clonazepam are 1,5 benzodiazepines. The tolerance is very, very less. Because the tolerance is very, very less, you can give on a long-term basis. So that's a very important clinical point. Though they all both belong to the benzodiazepines group, clobazam and clonazepam are 1,5 benzodiazepines, whereas midazolam, diazepam and lorazepam are 1,4 diazepines. Since there is tolerance, you give only for short term, whereas clobazam and clonazepam, since they are 1,5 benzodiazepines, the tolerance is very less and therefore can give on a long term basis. Another very, very important, fascinating point, especially for clinicians, is the clobazam being given as an intermittent therapy. We all know that the anti-epileptic drugs are given on a long-term basis. So we give on a long-term basis, but there are certain conditions where you anticipate seizures only for a particular period of time, and then they don't develop seizures at a later point of time. So we need to give a drug which acts only on the short duration and then you can stop it. This is known as intermittent therapy. So you give anti-epileptic drug only during that expected phase of person having seizures and then stop it. The classic examples are febrile seizures, catamenial seizures, and then hot water epilepsy, described by NIMHANS Dr. Sarachandra sir. So febrile seizures. What is febrile seizures? Febrile seizures, you see it in children where they are fine, they're alright, but when they get fever, they start throwing seizures. So when they get fever, they start throwing seizures. So you need not give anti-epileptic drug on a long-term basis. Only when you anticipate that they are going to have high fever and then they may start throwing seizures, only during that particular period you need to give anti-epileptic drug. And what is the anti-epileptic drug which can be given as an intermittent therapy? Clobazam. So the basic advantage of clobazam is that it can be given as an intermittent therapy. Likewise in women, some of the women have got a tendency to throw seizures during menstruation. So only during the 4 to 5 days of menstruation, they start throwing seizures. So again, you need to give an anti-epileptic drug, which can be given during the time when they are having menstruation, so that they don't throw seizures. So what is a drug which can be given as an intermittent therapy? Again, clobazam. So clobazam can be given as an intermittent therapy for febrile seizures, and in women the catamenial epilepsy, and third the hot water epilepsy. Hot water epilepsy is again a very interesting phenomenon. The people are alright, but as they start having bath with hot water, they may start throwing seizures. So when you expect them that they may have seizures because of hot water during that particular period, if you want to give an anti-epileptic drug as an intermittent therapy, you can give clobazam. So clobazam is a wonderful anti-epileptic drug which can be given as an intermittent therapy. Right. About clonazepam. Clonazepam is again a 1,5 benzodiazepine. It can be given on long-term basis. This is one drug which is really useful for juvenile myoclonic epilepsy, JME. Right. Now, coming to another drug, vigabatrin. Vigabatrin is the drug of choice for infantile spasms in tuberous sclerosis. So this drug is especially very good for infantile spasms in persons having tuberous sclerosis. But the problem with vigabatrin is that there is a restriction of visual fields. So you need to keep checking their visual fields often. Otherwise, they may have the restriction of visual fields. So vigabatrin is a very good drug for infantile spasms in tuberous sclerosis, and the only problem is that the side effect is the restriction or constriction of visual fields. Fine. Now, status epilepticus again. I want to talk about two important points about the status epilepticus. One, very important point. We need to understand this. Have you ever realized that during the early phase of status epilepticus, we give drugs like lorazepam, midazolam and diazepam, but at a later point of time we don't give these drugs. Why? What is the logic behind it? What is the pathophysiological basis of it? The pathophysiological basis is that status epilepticus, during the early period there is a decrease in GABA. During the early period of the status epilepticus, there is a decrease in GABA. But then as the time proceeds, as it goes on, traverses, at a later point of time, it is not because of the decrease in GABA, but it is because of increase in glutamate, NMDA glutamate. So because of the internalization of the GABA A receptor, and there is upregulation of NMDA receptors, glutamate, the pathophysiology changes. So initially, because the GABA is reduced in status epilepticus, you give GABAergic drugs like diazepam or lorazepam or midazolam. But as it proceeds, as it goes, now there is upregulation of NMDA glutamate receptors. So you have to give anti-glutamate drugs like ketamine. So initially you give GABAergic drugs. At a later point of status epilepticus, you give anti-glutamate drugs. Second important point is that, fine, if the person develops status epilepticus in the hospital, you have all the facilities, you can give diazepam, you can give lorazepam IV. God forbid if they develop any respiratory impairment, you have ventilator. But what if they start throwing recurrent seizures even before they enter hospital? At a pre-hospital stage, if they throw recurrent seizures and are in the process of developing status epilepticus, what can a doctor do? This has been clearly proved by a trial known as Rampart trial. What is Rampart trial? Rapid anticonvulsant medication prior to arrival trial. According to Rampart trial, it has been clearly shown that midazolam IM is non-inferior to lorazepam IV. So according to the Rampart trial, which says that midazolam IM can be given even before the patients come to the hospital, because there are no facilities, IM can be given, and midazolam IM may be non-inferior even to lorazepam IV. And therefore, the person starts throwing seizures at a pre-hospital stage where you don't have backup like ventilators to take care of his respiratory compromise, God forbid in case he has to develop, you can give safely midazolam IM according to the Rampart trial. Fine. Yeah. Now let me talk about the anti-epileptic drug in special conditions. So anti-epileptic drugs are not only useful in epilepsy and in conditions related to epilepsy, they can be given in other special circumstances also. So what are the special circumstances where these anti-epileptic drugs are used? One, migraine. In migraine or headache, severe headache, you can give anti-epileptic drugs like sodium valproate or topiramate. So these anti-epileptic drugs like sodium valproate or topiramate can be used even in migraine. So they can be used in conditions other than epilepsy like migraine as prophylaxis. Second, neuropathic pain. As I've already said when I was talking about oxcarbamazepine, for neuropathic pain you can give pregabalin as well as oxcarbamazepine because they are sodium channel blockers. They decrease the entry of sodium and hence limit the spread of the impulse. So anti-epileptic drugs, namely pregabalin and oxcarbamazepine, can be useful even for conditions other than epilepsy like neuropathic pain. Third, obesity. Obesity, the preferred drug, and nephrolithiasis, the drug you avoid, are two, topiramate and zonisamide. Topiramate and zonisamide are carbonic anhydrase inhibitors and therefore they are likely to induce renal stones, and therefore you have to avoid in persons who are likely to have some renal problems and predisposed to renal stones, or these drugs are preferred in persons who are having obesity, topiramate and zonisamide. Then women with epilepsy. I've already touched upon this topic. Pregnancy with epilepsy, the preferred drug is levetiracetam and lamotrigine. So pregnant lady with epilepsy, levetiracetam and lamotrigine are the drugs of choice. So any lady who gets pregnant and who's got epilepsy, you always put her on levetiracetam, a very very safe drug. There are no drug-drug interactions and therefore levetiracetam is the preferred drug. You can also give lamotrigine, but when you give lamotrigine in a pregnant lady with epilepsy, one thing you should watch for is the blood level of the lamotrigine, especially in the third trimester, because it keeps falling. From second trimester also it keeps falling, and therefore you have to keep monitoring the blood lamotrigine levels. So second trimester or third trimester, when you think the blood levels of lamotrigine has fallen down, you have to start increasing the dose of lamotrigine. But once after delivery, postpartum period, you can revert back to the normal dose of lamotrigine which she was been taking. Right. Now, coming to breastfeeding, there have been a lot of misconceptions regarding breastfeeding. Can anti-epileptic drugs be continued in a woman who is breastfeeding her child or not? Almost all the anti-epileptic drugs are safe. they are produced in very insignificant levels in the breast milk. So almost all the anti-epileptic drugs can be continued in lactating mothers except phenobarbital, which is found in significant quantities in breast milk. So other than phenobarbital, all the other anti-epileptic drugs can be given in lactating women. OCP failure. Some women may be taking oral contraceptive pills and they may be having epilepsy. So is there any problem? Are there going to be any drug-drug interactions? Yes. As I said earlier in my class, enzyme-inducing drugs like phenytoin, carbamazepine and phenobarbital, they are enzyme-inducing drugs. And oral contraceptive pills get metabolized by these hepatic enzymes. So when these drugs are given, namely phenytoin and carbamazepine, phenobarbital are given in a woman who is taking oral contraceptive pills, since it induces hepatic enzymes, they get metabolized fast, and therefore there is a risk of failure of oral contraceptive pills, and the woman is likely to become pregnant. So a woman who is already epileptic and taking phenytoin or carbamazepine, and on top of it she is taking oral contraceptive pills, you need to give this advice that there is a chance of a failure of her oral contraceptive pills. Mood instability. Some especially in psychiatric practice, we see persons having mood instability. So an anti-epileptic drug, which is a good mood stabilizer, is sodium valproate. So sodium valproate can, not only in epilepsy, we can use it as a mood stabilizer also. So I've covered as far as possible almost all the important and essential points of epilepsy and anti-epileptic therapy. So I really enjoyed giving a lecture on anti-epileptic therapy, and I hope you've also really enjoyed listening to my talk. If you have liked my talk, please like and subscribe my channel, my YouTube channel, Dr. Sreenivas Medical Concepts, my Facebook page, Dr. Sreenivas Concepts. Thank you. Bye.